Hello and welcome to The Leading Question. I'm your host, Steve Wigrizer. This year in the United States, there will be 2 million new cases of cancer diagnosed. More than 600,000 people will succumb to this disease. Today's leading question is, will there be a day, hopefully soon, when we can eliminate this disease or at least greatly reduce cancer mortality? To help us answer this question, we have with us today on the show a cancer specialist and oncologist, Dr. Moshe Chasky. Dr. Chasky, welcome to the show.
Nice to meet you, Steve.
Good to meet you as well. Well, we might as well jump right into it. What's your answer to today's leading question?
In terms of decreasing mortality and patients living a lot longer and even being cured of the disease, the easy answer is we have made amazing strides since I was in medical school. And I think the classic example in this is when I started medical school in around 1998 for multiple myeloma, we almost had no treatments. There was melphalan, prednisone, there was a drug called thalidomide coming on the scene. Patients would live with multiple myeloma 3 years, really terrible quality of life with it. And now you have many patients with multiple myeloma that we're treating with various targeted agents, which we'll get into. And patients are living, many of them, more than a decade, and some much, much longer. In terms of curing the disease, we definitely have more cures than we had in the past. We have patients with stage 4 solid tumors such as melanoma, lung, that are living more than 5 years in deep remissions and may never recur with the disease. These are patients that would have definitely died from their stage 4 disease, which had spread throughout their body. They would have definitely died years ago. But today, many of these patients are living a long time and will never recur with this disease. If you ask me whether we'll ever cure this disease, I don't see us getting rid of cancer, because I think saying that we're going to get rid of cancer is saying that we're going to live forever. So I think that we will always try to stay in front of this as long as we can. But we have definitely seen patients live a lot longer with cancer and with a better quality of life, and definitely pushing the cure in many more cancers.
Well, those are some very optimistic words. I want to unpack some of that. You used an example of multiple myeloma. As I understand that, that's a bone cancer or a blood cancer. Do I have that right?
Yes. So multiple myeloma starts out in the bone marrow, and it starts out as a blood disorder, but it starts affecting many different parts of our body, and it starts causing anemia, so that causes people to be very fatigued. It causes their calcium levels to go very high, and that occurs as a consequence of breaking down of bones. And you also have in these patients where they go into kidney failure. So years ago, patients with multiple myeloma would die very quickly within a few years with an impaired quality of life, almost being bedbound and in pain because of broken bones and having the consequence of kidney failure. And before the days of dialysis, of course, they died soon, but even with dialysis, they would only live for a very short period of time. And within a few years, all these patients died. And now we have treatments where patients come into the office, and the initial treatment for multiple myeloma today involves 4 targeted agents that we're giving. We give a steroid, we give a drug called daratumumab, which is a targeted agent. We give a drug called lenalidomide, which is also targeted. We give another drug called bortezomib. None of those drugs are chemotherapy. When I started my career, we always thought that more chemotherapy was better. And there's a beautiful book called The Emperor of All Maladies, meaning the Emperor of All Maladies, the malady being cancer. And it's written by a guy by the name of Siddhartha Mukherjee. And it's sort of the biography of cancer. And he goes through the history of cancer and how we've gotten to where we are today in cancer treatment. And one of the things he talks about is this really tough history that we had in oncology, where we just thought, oh, you didn't give one chemotherapy drug, give 2 chemotherapy drugs. You didn't give 2 chemotherapy drugs, give 3 chemotherapy drugs. Oh, you couldn't give that to do a bone marrow transplant and go even higher on the doses. And what we learned was that you hit a ceiling where more was not necessarily better. But now we have these targeted agents where patients could actually go on and live a great quality of life. We have many patients that are going to work right from my office. Many of our patients walk into our office, they're taking pills that are targeted. They come in for their visit and they leave. They see us once a month, once every 2 months. We have many patients that are coming to see us every few months and getting their pills and doing amazingly well with different diseases. The fascinating thing about cancer, which is different than an oncology, which is different than infectious disease, is when you look at infectious disease, you have bacteria, you have viruses, you have parasites. Most of the times when we get a virus, our body sees the virus as something that's very different than us and able to go after it and kill it. And then we go on with our regular life. So our immune systems react to it, we get rid of it, or we get a bacteria, we take an antibiotic, and the antibiotic is able to target the bacteria because the bacteria has cell walls, which looks very different than the human body. And there's very little side effect when we take these antibiotics because these antibiotics are able to easily target the bacteria. And we've had this for decades. The challenge with cancer is us. The cancer cells, a tumor, is our own cells that are just evading the immune system. You could think about it as an enemy that has figured out a way to infiltrate into the foreign country and wearing the same clothing as the foreign country and able to continue to divide in this foreign country, which is our own body, and then start spreading and dividing and doing harm. Many of our cancer cells actually put a mask on it. They put a mask called PD-L1. They actually put a mask that tells the immune system, don't attack me. It tricks the immune system into thinking that I am one of you. Let me continue to divide. Wink, wink. I'm going to continue to divide until I kill you. And that's basically the way tumor cells get away with it. And what we didn't really understand, and I started to talk about all these new advances about targeted therapies, and we'll get into immunotherapies. But one of the challenges of targeting cancer, as opposed to, we talked about antibiotics attacking a bacteria. When an antibiotic attacks a bacteria, we said a bacteria looks very different than our entire body, than the human body. So an infectious disease specialist is able to give an antibiotic and have very little side effects associated with it. However, with a cancer cell, that cell looks like you. So the only way to stop division of that cancer cell, actually until the late 1990s, until all these targeted developments came up, was to give what we called chemotherapy. And chemotherapy was basically attacking all dividing cells. And therefore, the side effects associated with chemotherapy was any cell in our body that was dividing. What cells in our body are dividing quickly? Our hair, the mucosa in our mouth. So our mouth, we would get mouth sores from it. Our blood cells are dividing quickly. So all of a sudden, your white blood cells would be very low, and you'd end up in many occasions when you got chemotherapy, you'd end up in the hospital with an infection because the white blood cells went too low, because the chemotherapy wasn't targeted against the tumor itself. Yes, you wanted to hit the tumor with the chemotherapy, but unfortunately, it's hitting many other things. Now, chemotherapy still has a role, but we're getting to a point that we're understanding that we need other treatments, other modalities of treatment besides for chemotherapy. I spoke at the beginning about how we realized that we hit the ceiling of how much chemotherapy a person could tolerate. We also hit the ceiling of how much a tumor was going to respond to chemotherapy. You could give more chemotherapy, and then all of a sudden these tumors would find ways to resist this chemotherapy. We needed to find other ways. And that's what I've seen in my career over the last couple of decades, which has just been amazing. This amazing explosion, burgeoning, flourishing of this of the field, that we started to hit these cancers in so many other different ways that I think we wanted to go into.
How do you possibly keep up with all the developments, with all the different types of cancers in your practice?
So in our practice, first of all, there's a car ride in where there's many review lectures, and we are always listening to podcasts. We go to lots of conferences. I think one of the things that came out of COVID was a lot of these conferences are now virtual. So I'll spend many times on the weekend, an hour here, an hour there, listening. There are other ways that we keep up. First of all, there are NCCN guidelines, which is the National Comprehensive Cancer Network guidelines, where you basically have an algorithm for many, many different cancers, and actually most cancers out there. There's what we call NCCN guidelines. So you could be assured in most cases that whether you're going to Memorial Sloan Kettering or to a little oncology practice in Alaska, they're probably going according to NCCN guidelines, which tells you exactly how each cancer should get treated. Now, every patient is different, and no tumors are exactly alike. So that's very general.
So that can be varied. The secret sauce can be varied.
The secret sauce could be varied from patient to patient. So one of the ways, first of all, we get genetic signatures on most tumors, and we get genetic signature reports that tell you, okay, someone has a lung cancer, and this patient has an EGFR mutation or an ALK mutation, and you know, based on those genetics, you should give this and this drug. Right. The other way is that there are other things that we can get online very quickly today. There's a resource called UpToDate. There's another, what's amazing, and I think we talked about this yesterday a little bit, is AI, artificial intelligence, has changed our world. So there are amazing apps that are far more evidence-based than Google or ChatGPT. There's something called Open Evidence, and there are many other apps that are starting to develop in this, where literally within seconds you can ask a complex question on a patient, and within seconds you'll have an answer that doesn't tell you exactly how you should treat the patient, but it gives you guidance. And then the other thing is you have colleagues. So there's many times when we're in each other's offices asking each other questions, and then we're actually blessed in Philadelphia to have an amazing network of doctors that I wouldn't look as competing against one another. The way I look at it is we're all in this working together for the patient.
So with the benefit of the guidelines, with the benefit of your collaboration, and with the benefit of the amazing resources that we have here in the Philadelphia area, you're not only the treating doctor, but you're also the quarterback. You can direct the care even if the care doesn't occur at your facility. But I want to talk a little bit about your particular practice too, and in the context of your answer to that question.
Yeah.
So tell us about Alliance Cancer Specialists, please.
So when I joined the practice at a fellowship from Fox Chase in 2008, I joined a small practice. It was just about 6 doctors in the greater Philadelphia area, which was in Northeast Philadelphia. It was in a hospital which was called Frankfurt Torresdale. We served Frankfurt Bucks, and we served Frankfurt as it was known in North Philadelphia. And we realized over time that the days of hanging a shingle as a private practice and being 1 or 2 doctors or even 6 or 7 doctors, it was just tough to survive in the city of Philadelphia or in most places across the country. And we decided that we would just have better resources for our practice if we joined up together all of the independent practices that we could within the city. And our practice joined up with a practice up in Bucks County in the Langhorne area in St. Mary's. And then we joined up with a practice in Doylestown and in the Sellersville area, and then another practice in the Ridley Park area in Sellersville, and then another practice then in the Lankenau area for Mainline Health, and then another practice in the Abington area. And the shared resources, so we have one chief nursing officer, we're able to do quality controls for all of us together. We talked about a collaborative relationship we have with academic centers, and specifically we have a wonderful collaborative relationship now with the University of Pennsylvania, where we're able to get patients down there, get the patients back. We meet with the doctors there on a regular basis to discuss difficult cases every few months. We have quality controls where they look at our charts. We meet with them on a regular basis. So there's a lot of good that came of coming together.
And how many oncologists are there working with you at Alliance Cancer Specialists?
So it's about 25 community oncologists, and we have excellent physician assistants and nurse practitioners, and we have infusion nurses, and yeah, we've built a wonderful practice that we're very proud of.
And I'm imagining that you're quite busy.
We are very busy, but every patient in our practice is made to feel like they are the only person that matters. And I think that's the beauty of it. That yes, you could have a busy waiting room, but every patient needs to feel like they are the most important person in the world.
So we talked a little bit in the context of a small number of cancers about treatment. And I want to talk a little bit more about it because there have been so many changes during the course of your practice and over the past decade. Is it possible to prevent cancer?
Yes, there are things that we could do to prevent. As an oncologist, we often are dealing with the other side of things when people already have cancer.
Understood.
And I will say that I'm a better treater than a person that you come to for prevention, because I think that is really up to the primary care physicians there for prevention. But it's the most important thing. I often compare it to Willie Mays. They say he was always under the ball when he made a catch. He didn't look like he was making the saving catch. He just made it look easy. Prevention is the best way, is to get there before it happens. And things that we could do today in terms of prevention are eating better, not being obese, exercising, not smoking, not drinking as much alcohol or any alcohol according to the newest studies that have come up. There are things that we could do. And then there's also screenings. Nobody should get cervical cancer which is a cancer that is caused by a virus, HPV, or human papillomavirus. First of all, the younger people should be vaccinated today to prevent it. And all women should be getting pap smears on a regular basis and seeing a gynecologist, because the cases that we see from cervical cancer are 100% preventable had they been screened for it. And there's other things like colon cancer, where we could prevent it by getting colonoscopies. Women should be getting their mammograms on a regular scheduled basis. So yes, there are many things that we could do for prevention, and it's important. That is the best thing that we could do, is to prevent.
Well, it sounds like you work very closely with primary care physicians, family doctors, internists throughout the Delaware Valley. Is that where your patient base comes from?
For the most part, it's primary care physicians, and then it's surgeons in the area. And then it's a lot of people have family members that have been treated with us and understand our care and understand the personalization of care that we've given and want their own family members to go. So a lot of it is self-referrals, but many primary care physicians refer into us. And one of the things we do in our practice with the primary care physicians is, and this is different than I think many hospital-based centers or academic centers, is we don't wait for the cancer diagnosis to see a patient. If there's a suspicion, someone is having belly pain, weight loss, they have lymph nodes that are being felt, we don't tell the primary care physicians, oh, get the biopsy and then send them over to us. We get that patient in right away because we feel that the sooner we get the patient, the earlier that we could intervene, the better their care, the better their experience. We could move things much faster than a lot of the primary care physicians just because we're connected to that network.
And you can get them to surgery and get them to treatment a lot quicker. And, you know, I've always been told that cancer is a pathological diagnosis, meaning you can suspect cancer.
Correct.
But you can't make the definitive diagnosis of cancer except under the microscope. And maybe a good example of that would be an individual goes in for a chest x-ray.
Yes.
And there's a density that's there, or there's something that looks like a nodule, there's something that looks like a cyst, and you look at the x-ray and you as a physician say, gee, I really don't know what that is. Now, you may choose to watch it, depending upon its appearance, because, correct me if I'm wrong, most cancers over time are going to grow.
Yes.
And you may come to the conclusion there's no growth or no change in its density. You may agree to take it out or refer the patient to a surgeon to take it out, but it may not be a cancer. Yeah. Is that a common situation that you find yourself in?
Very common situation where you're often able to just either watch it or you get a biopsy of something that looks like cancer, and then it turns out that it's not necessarily cancer, it's benign, and that it could be watched. Or then on the other side, we recently saw a case of a relatively young guy in his 40s that was a smoker, had a lung tumor, looked like, okay, this is going to be lung cancer, and then it actually turned out that it was benign. But it's growing. It's not going to spread anywhere, but it's growing, and we still need a surgeon to take it out. So we directed the care. We were the ones to get this patient in right away. We got the biopsy. We made sure it was benign. We got in contact with the thoracic surgery team at the University of Pennsylvania, got them seen the next week, and they're already scheduled for surgery. And that's just the way we work.
Let's say you get the diagnosis that you don't want to get. What is the important next step that a patient must take?
I think you want to get to your quarterback as soon as possible. You want to get to your quarterback that's going to direct your care, someone that you could trust to get you through the process. And primary care physicians are wonderful, and you could ask your primary care physicians who they would send to. But I think at the end of the day, in most cases, a medical oncologist will get you from point A to point B in the quickest way if there's a suspicion. Even if it's a surgical diagnosis, a medical oncologist will know who the best people are in that field to take that tumor out when it comes from a surgical standpoint. So I think you can never go wrong from my standpoint, in having a medical oncologist be your quarterback. And I think many surgeons would agree with that statement, and surely radiation oncologists, I think many would agree that when medical oncologists quarterback the care, it just makes it more seamless for the patient.
And you will see the patient even before they have biopsy-proven cancer?
Absolutely. Absolutely. And we know that some of these cases will turn out to be benign, and that's okay. And we continue to see the patients if we need to, or we say there's really nothing to worry about and we'll see you if needed again, and that's okay.
We're sitting here in 2025, and if I could get you to peer into your imaginary crystal ball, where do you see cancer treatment going over the next 10 to 15 years?
I think there will be less and less chemotherapy. that if you're giving chemotherapy, it's a part of the treatment, but it's not necessarily the mainstay of the treatment. We haven't gotten into this, but the immunotherapies have completely transformed the field of cancer. And the first immunotherapies came out in 2010, where basically we talked about this before, that every cancer or many cancers, they mask themselves from the immune system to evade and be able to divide. And we know that if we unmask the tumor and allow the immune system to attack it, it works. Now, those immunotherapies were given as infusions, and they continue to be given as infusions in many cases. Now, all of a sudden, many of those are just being subcutaneous injections. They're injections. We're seeing so many more drugs that are just being given as oral agents, as pills. I think that's where the field is going, is more immunotherapy to understand how we could attack these tumors from an immunotherapy standpoint, how we could target it, how we could target some of these cancers and have less side effects associated with it. And sometimes we actually use both. We didn't get into this, but we talked about this a little bit. There's a new cancer treatment on the horizon that we're already using in lymphomas and myelomas, where you have what's called bispecifics. It's actually being given now in small cell lung cancer as well, where there's a target on the tumor, a genetic target, where the drug is able to get to that target, it hits the target, and then on the other side, the reason it's called a bispecific is it pulls in the immune system to not attack everything in the body, but to attack that target, that lung cancer, that lymphoma, that myeloma cell. So we're in an amazing place. And then the side effects with those are much less than, say, bone marrow transplants and high doses of chemotherapy. So yes, I think we're getting to a new day and age that, first of all, I think we'll cure more. But even if we don't cure, I think patients are going to continue to live better, higher quality of lives for a longer period of time. There's nothing that makes me happier, and this gets me emotional, but people coming to our office and hitting another birthday of a grandchild, a great grandchild, another event in their life, and being able to actually attend it, and in many cases not even looking like they're a cancer patient anymore.
Your enthusiasm for the field is obvious, and if any of our viewers want to reach you or reach your practice, how would they do that?
They could always reach out to us on our website.
So, Dr. Chasky, I think I know at least part of the answers, but when people look back on your career, how do you want to be remembered?
This is a question that I thought about this weekend because someone asked me, Moshe, are you going to slow down? You hit 50 years old, are you going to start slowing down in your career? And I said, I think I'm just getting started. There's not a lot of things in our lives that we're great at. We talked about this a little bit before. Everyone is good at their niche in the world. And when you find the niche that you're really good at and you know that you could succeed at, that keeps you going every single day and makes you strive to be the best at what you do. And that's what I want to be remembered for, is going all in for every single patient that I take care of, no matter from any walk of life. And there are patients that can't get to my office, and I told you I'm old school on this. I go to several patients' houses if they need to. Right. And they can't get to the office because the transportation is too difficult. I do that because it makes me feel like a real doctor, like a real old school doctor. My grandfather was a pharmacist and used to deliver drugs to people's houses. That was why I went into medicine. I want to feel like a real doctor, that I'm really caring for the people in the community.
Well, I have no doubt that you are. It was a pleasure meeting you. I hope we can get you back on the show. And to our viewers, stay thoughtful, stay informed, and don't be afraid to ask the leading question.